Welcome to the Public Accounts public hearing relating to report number 59 of the Director of Audit on the results of value for money audits, which were tabled in the Legislative Council on 14th November 2012. The Public Accounts Committee is a standing committee of the Legislative Council. It plays the role of a watchdog over public expenditure through consideration of the reports of the Director of Audit laid before the Council on the government accounts and the results of value for money audit of the government and those organizations which receive funding from the government. The consideration by the committee of the Director's report involves gathering evidence relevant to the facts contained in the Director's report, so that the committee may draw conclusions and make recommendations in a constructive spirit and forward-looking manner. I also wish to stress that the objective of the whole exercise is such that the lessons learned from the past experience and our comments will enable the government to improve its control over the expenditure of public funds with due regard to economy, efficiency and effectiveness. The consideration of the Director's reports follow an established process of public hearings where necessary internal deliberations and publication of the committee's report. The committee has an established procedure for ensuring that the parties concerned have a reasonable opportunity to be heard. After the committee is satisfied that it has ascertained the relevant facts, it will proceed to form its views on those facts, followed by a process of formulating its conclusions and recommendation to be included in the report. In accordance with Rule 72 of the Rules of Procedure of the Legislative Council, the committee is required to make its report on the Director's report to the Legislative Council within 3 months of the date at which the Director's report is laid on the table of the Council. Before then, we will not, as a committee or individually, be making any public comments. Following a preliminary study of the report number 59, the committee has decided in respect of 4 chapters in the report, and possibly more as we study more of the report of 59 report, to invite the relevant public officers to appear before the committee and answer our questions. We have, apart from this hearing, also set aside December the 3rd, December the 7th, and 15th December 2012 for public hearings on the other charges. On the other chapters, my apologies. The public hearing today is on Chapter 3 of the report number 59 of the subject, Regulatory Control of Private Hospitals. The witnesses are Dr. Goh Wing-man, Secretary for Food and Health, Mr. Richard YUEN, PS for Food and Health, Professor Sophia Chen, Mr. Chris Sun, Dr. Constance Chen, and Dr. Amy CHIU. I will now invite members to declare interest in relation to the subjects chapter covered in this chapter. 我想申報咧，我自己申報先好嘛？我係呢個香港大學嘅council member。我了解到咧，香港大學會係。
Well, I need to declare interest first. I understand that for the organization I'm affiliated with, they will be make an application as well. And I need to declare that I am a board of director of a number of companies is on the register. Other members? I'm also a core member of the Hong Kong University. So Paul and I are representatives on the Hong Kong U Council. Any other members would like to declare interest? No? Secretary, would like to address the committee? Thank you, Chairman. Now, on your declaration of interest just now, I need to say this because before July I was a private medical practitioner and I worked in one of the hospitals mentioned in this report. I have no other investments or interests. So may I say a few words? Yes, please do. May I be seated while I address the committee? All right. Yes, you may be seated. No need to stand up. Thank you. Chairman, members. First of all, I thank the Chairman for allowing me this opportunity to give a succinct and general response to the audit of the report of the Director of Audit on regulatory control on private hospitals. And I would also like to take this opportunity to brief you on the various improvement measures in response to the Audit Commission's recommendations. At present, private hospitals in Hong Kong are regulated under the Hospitals, Nursing Homes and Maternity Homes Registration Ordinance, Cap 165. They are required to be registered with the Department of Health and to comply with the department's requirements on accommodation, staffing, and equipment. Apart from the current regulatory framework, the Department of Health in 2003 issued a code of practice which sets out the standards of good practices on areas, including the management structure of private hospitals, quality management, patient care, risk management, clinical standards. Compliance with the COP requirements is a condition for registration with the Department of Health. Through these licensing conditions, the Code of Practice facilitates the Department of Health in monitoring more extensively the various service areas of private hospitals. The latest major amendments to the law on the regulation of private hospitals were made in the 1990s. Over the past few years, the ecology of healthcare has undergone substantial changes. Also, the community has been very concerned about the safety, quality, and the price transparency of private hospital services. We will extensively review and amend the legislation on regulation of private hospitals. In particular, we will make reference to and implement the audit recommendations and draw reference from international standards and overseas experience in order to enhance the safety, quality, and transparency of private hospital services. We've already established the Steering Committee on Review of the Regulation of Private Healthcare Facilities to review the regulatory regime for private healthcare facilities. The Steering Committee held the first meeting on the 2nd of November and set up 4 working groups, one of which will focus on reviewing the direction and measures related to private hospitals. We will announce the membership of the working group shortly. The scope of the review includes whether the standards for private hospitals should include more elements of healthcare services. That's apart from the 3 areas I mentioned, whether the sanctions for non-compliant private hospitals should be amended, as well as a focused research on how to enhance the price transparency of private hospitals to protect patients' right to know so that patients can choose the services that best suited them. The review is expected to be completed within a year, to be followed by public consultation on the recommendations and the initiation of the legislative process. And the Department of Health understand that time is needed for the review, and meanwhile, the Department of Health has proactively adopted measures to step up its monitoring of private hospitals on the basis of the audit recommendations. They include, first, on the existing basis, and that is requiring private hospitals to submit inspection reports and conduct item-by-item inspections according to the COP. The Department of Health will compile a suitable inspection checklist and standardize a format of inspection reports so as to ensure that private hospital service areas are fully inspected, and also for the result of the inspection to be recorded in a standardized manner. In addition, in order to monitor whether private hospitals are compliant with the land grant conditions, the DOH has also compiled a detailed checklist for this purpose, which will be incorporated under the mechanism. Secondly, the department will regularly review and closely monitor the Sentinel event reporting system and will issue advisory or warning letters to non-compliant private hospitals. As for sentinel events involving professional misconduct or substandard performance, the Department of Health will directly refer the cases to the relevant professional disciplinary bodies for investigation and follow-up. In establishing the Sentinel Event Reporting System, the Department of Health will make reference to international practices such as the guidelines promulgated by the World Health Organization. That is, a successful system should be non-punitive and confidential and lead to constructive responses. Thirdly, the Department of Health has begun to develop guidelines to assist private hospitals in closure arrangements. This is rare, but still it has happened, so procedures will also be developed to assist the inspection of private hospitals which will be closed soon. Chairman, members, we are determined to enhance the regulation of private hospitals. We will learn from past experience and give serious consideration to the audit recommendations and members' views so as to formulate a comprehensive regulatory regime to enhance the service standards and price transparency of private hospitals and to offer better protection for members of the public who can afford private health care. I so submit, Chairman. Thank you, Mr. Ko, or Dr. Ko. Let's proceed with questions. Mr. Alan Leung first. Thank you, Chairman. Secretary. Perhaps I'll say something about your opening address first. Just now you said that the existing legislation, and that is Cap 165, Hospitals, Nursing Homes and Maternity Homes Registration Ordinance. The ordinance was enacted in 1936. The major amendments or major review was made last in the 1960s. So if you do not have this report from the Director of Audit, you will not set up this steering committee on the regulation of private healthcare facilities. Well, Secretary, I don't think it has to do with you. You have just come into office for several months. But on behalf of the administration, you should take this question. Why is it that since year 2000, you had conducted a review on the ordinance, but it wasn't until this report of the Director of Audit that you set up this steering committee? So in terms of regulatory control of private hospitals, does it show that the administration is not taking a hardline approach so that no protection or inadequate protection is offered to the public? I'd like the Secretary to answer this question first. Chairman, thank you, Mr. Leung. Yes, sorry. Now, I agree with Mr. Leung's factual part of the question, and that is when this legislation was enacted, when major amendments were made, and a review was conducted in year 2000, and no further move has been made in amending the legislation. I agree with that. But in terms of our attitude, I don't agree with Mr. Leung. In fact, after the review, we did consider conducting a review or making amendments. But around year 2000, the economic environment in Hong Kong was very bad. I believe members will also recall that, in fact, around year 2000, there was the Asian economic crisis and Hong Kong was affected. Even before the SARS outbreak, for quite some time when I was working in the hospital authority, I learned that the utilization rate of private hospitals was very low, largely due to the poor economic environment. And also due to the fact that services of public hospitals had improved. So many people opted for public hospitals instead. And after the SARS outbreak, utilization rate of private hospitals became even lower. And many private hospitals were running at a loss, and some of the hospitals were considering closure. So if the administration still headed towards stepping up regulatory control and amending the legislation against this background, and as you understand, if you step up regulatory control, it would be harder for them to operate. And this is the background as I gathered, and no further action had been taken. However, as far as the Department of Health is concerned on the review of the legislation and stepping up the regulatory control of private hospitals, it has all along been on their agenda. But in terms of priorities, perhaps no top priority has been accorded, and therefore no follow-up was ever made. Now, from the perspective of a legislator, of course, we need to safeguard the public's right. Even if the private hospital is used by one patient only, we still need to be concerned about the safety of this one patient. I hope Secretary would also agree with me. Just to follow up, now after hearing the Secretary's explanation, there may be other issues that in the view of the administration should be accorded high priority. And therefore, the review which started in year 2000 was set aside. Now, the purpose of this hearing today is to allow witnesses to attend and give an account before we draft the PAC report. So if there are points that you think the PAC must consider before we make criticisms or recommendations in our finalized report, if there's anything we should know, and this do not only apply to the Secretary but to others, representatives as well, you should speak up. Otherwise, our report will be based on what we've heard during the hearing only. So, Secretary, if, according to your answer, the utilization rate of private hospitals was not as high as what we're seeing now, and that's the reason why the year 2000 review was suspended. Well, actually, I myself do not accept that. Of course, the finalized report will be a collective decision. But Secretary, I'll give you another chance. Apart from the low utilization rate of private hospitals, are there other factors for consideration so that we don't give harsh criticisms in our report in relation to this lenient and outdated regulatory regime of the administration on private hospitals? Secretary, you have heard the question. Well, you gave a brief answer just now. Perhaps you can give us more information and give a detailed answer in relation to the question. Thank you, Mr. Leung, for giving me this opportunity to supplement my answer. As I said, the private hospitals had a low utilization rate. They were running into operational problems. And in fact, around year 2000, I can say that as far as the atmosphere of the community is concerned, apart from the healthcare system, I think that overall speaking, the sentiment in the whole community is the sustainability of the healthcare system.
At the beginning, when the hospital authority was established in late 1980s to early 1990s, society is most concerned about the service quality of public hospitals, the environment and the service culture and efficiency. When the hospital authority was established, the biggest responsibility is to improve healthcare quality, enhance the efficiency of the operation and the efficiency of resource allocation, and to improve the service culture of hospitals. There is another motive that was actually understood, is to review the sustainability of medical financing, but that was lower down the agenda. The sentiment in 1990s was to improve the overall service quality and service culture. And the atmosphere at that time did not really allow the hospital authority to deal with the matter of sustainability. This matter was mentioned, but it was not handled. In late 1990s, because the points made above were even more serious, the sustainability of public hospitals was a big issue. At that time, the Harvard report said that the resources of public medical system was like a snowball. 20, 30 years ago, later, there may be a burst of the whole system. So will it be the case that the hospital authority was doing too well, and then there might be a problem with sustainability? So the focus at that time is to allow the system to be more sustainable, to achieve a better balance between the public and private sector. This is the background I would like to talk about. There is another point which members can consider, and that is, at that time, there was some consideration about a review, but it was not continued. It doesn't mean that the government or the Department of Health did not do anything. We have to enhance review, and we have to improve service quality. Apart from making laws, there are a lot of other ways, and there is a lot of essential work. Then in the year 2000, when the Code of Practice was issued, better Code of Practice was established on, for example, clinical standards, patient management, and so on. And upon annual registration of private hospitals, not only the three things mentioned in the law, for example, the accommodation, staffing, or equipment, these are not the only things. Those three terms are rather abstract. If you consider facilities, equipment, manpower, these are rather abstract terms. In 2003, there was the Code of Practice. Looking back, this is a rather comprehensive system, so that the Department of Health on one hand can regulate the hospitals, at the same time they can give guidelines to hospitals to improve their management and service to patients. So in fact, a lot of concrete work had been done. I hope you'll agree that, of course, legislation is the core in regulation, and the law gives the Department of Health the power to register or not then sometimes the details may not be enough. And it is a big exercise to amend the law. And before that is done, using a code of practice is helpful for both the Department of Health and for the private hospitals. So at that time, even though we did not amend the law, we did not revise the structure, however, we worked with private hospitals on a lot of improvement measures. Mr. Alan Leung, thank you, Chairman. Thank you, Secretary. We would have some chance to test the Secretary's answer. In the year 2000, there was no amendment of the legislation, but in relation to the Code of Practice, there are stringent requirements on accommodation, staffing, and equipment. And every year when the private hospitals apply for registration, there are some safeguards. So it is going to be a focus of today's hearing as to whether these are effective or not. There will be a lot of chance for us to deliberate further. Thank you, Mr. Leung. Mr. Kenneth Leung. I'd like to discuss with the Secretary and the Director about inspection of private hospitals. My question consists of two parts. Let me start with the first part, referring to the audit report. If I may refer you to para 2.6 on page 6. There is a table 1. Inspections conducted in 2009 to 2011. If you look at a total number from 2009 all the way to 2011, there is quite a big increase. In 2011, 134. Comparing with 2010, the increase was 40%. Comparing 2009 and 2011, the increase was 78%. Did manpower increase for these inspections? That's my first point. Secondly, I understand that the ICAC in the 2010 February report, well, this report was mentioned in the audit report, and in law enforcement, the Department of Health adopted a partnering relationship or a partnership approach with the private hospitals instead of a regulator's approach. So I would like to ask the Bureau or the department for a response. This is a structural issue which I would like to seek clarification. Thank you, Chairman. Thank you, Mr. Leung. The Department of Health is the enforcing agency of CAP 165. Even before I joined the government, I knew that the Department of Health faced manpower problem. Inspection of a hospital is a very complicated exercise. I have not inspected a hospital, but I often visit hospitals. Every time when I visit the mainland or other countries, I am invited to visit hospitals. So very often I only visit a few departments, but then usually I spend a whole morning or a whole afternoon. So inspecting hospitals is a very complicated exercise. The Department of Health won't have all the necessary expertise to inspect the hospitals. I can confirm this point. For example, my specialty is orthopedics, and when I visit hospitals, how am I to judge the operation of other departments, whether or not the equipment is appropriate, or let's say when I go to a radiological department, those staff may be telling me that a certain equipment is state-of-the-art, is very advanced. Then Well, because I am not working on that area, so I won't know too much. So I understand that the Department of Health will encounter such a difficulty. And it is unreasonable to ask the Department of Health to employ experts in all areas. So I understand that in the Department of Health there's a core team. But in different areas of specialty, the Department of Health has to consult other professionals to make a decision. I will defer to the Director of Health to explain all the constraints and difficulties, but I must admit that the manpower is tight and demands are getting higher. So there's the pressure to increase manpower. Besides, they have to seek professionals from outside. Concerning the point made by ICAC on the partnership approach, ICAC must have their reasons in making this point. But from my point of view, under different circumstances, sometimes an organization responsible for enforcing a certain legislation will always face a dilemma. On one hand, you are a law enforcer. On the other hand, you have to consider or treat the operating organizations as partners. If you only tackle these issues from law enforcement point of view, whether your work will be effective is one thing, and your final goal through law enforcement is to improve and make sure that service quality is good and to safeguard public health. So let me digress a bit. Another department in our bureau always faces this issue, whether or not the target of law enforcement are merely targets or are they your partners? Our hawker control team often encounters this conflict. Now, sometimes there are a lot of complaints that hawkers obstruct the streets, so we have to enforce the law. And law enforcement has to be done in a very strict and impartial way. But then if you do not have a partnership relationship with them, if you don't understand their difficulties and pains, then how can you help the overall operation and improve business environment? I do not disagree with ICAC, but my view is you have to enforce the law fairly, but to a certain extent you have to treat them as working partners. You should join hands to improve service quality so as to safeguard the public. Now, I would like to leave some time for the Director of Health to explain. Director, thank you, Secretary, and thank you, Mr. Leung. Concerning the number of inspections and manpower allocation in 2011, there is quite a big increase. One of the reasons is on follow-up inspection. So we did follow-up inspection on certain incidents because there were a number of incidents that year. So there is a big number under this item in that year. As regards manpower, after the year 2000 review, in 2000 to 2004, at the beginning, we did not have much manpower. A chief doctor of the headquarters was responsible for regulating private hospitals. In his team, there are 4 professional grade personnel, senior doctor, nurse, and administrative officer. So in other words, there's only 1 clerical colleague. Under the chief doctor, there are 4 professionals only, and there is a clerical staff, altogether 5 people. In 2005, we beefed up the professional team. There are 2 more doctors. For the other grades, They also had to inspect schools. At that time, the inspection unit was set up. So we increased the number of doctors. In the team, there were at that time 12 people, including 6 professional-grade colleagues. This number was kept all the way till 2011. In 2011, again, we beefed up the professional team. Comparing with 2005, when there were only 6 professional staff members, in 2011 there are 11, 2 senior doctors, 3 doctors, and 4 nurses, and 2 administrative or executive officers. So our establishment, our manpower is equivalent to the situation in 2011. Mr. Leung, you said there are 11 colleagues. So in other words, there are 11 professional staff members in the inspection unit. Do you have other supporting staff members? The person responsible for that unit is a chief doctor. Half of his work is responsible to regulate private hospitals. So in other words, half a chief doctor, 2 senior doctors, 3 doctors, 4 nurses, and 2 administrative officers. And these people were responsible for inspection. So these 11 people worked on all hospitals. Yes. Sorry, Chairman, I'd like to continue to follow up. In the coming few years, do you have plans to hire more people? Yes. Can you explain your plan? Can you answer after being called upon by me? Okay. Thank you, Chairman. We will consider the audit report, and as the Secretary said, the government has already set up a steering committee on review of private hospitals, and one of the working group will be responsible to regulate private hospitals. And one of the work areas is to increase manpower. Mr. Leung, perhaps you can follow up later, because the Secretary was not able to answer your questions in a satisfactory manner. I will let you follow up later. Mr. Paul Zhe, and then Wang Yukman and Lang Sing. Thank you, Chairman. We understand the difficulties explained by the Secretary. Between law enforcement and partnership relationship, a choice has to be made. But Secretary do agree that there must be a right balance. If we read the audit report, if we refer to the findings in para 2.19, table 2, number of inspections, and also the regulatory actions, for example, warning letters and prosecution actions. Over the past years, there was no prosecution. Number of warning letters issued is on the low side.
So, Secretary, how do you explain that you have already struck a balance between law enforcement and partnership? In our reply to the audit, you can see that we agree with the audit on this point. That is, when it comes to law enforcement and the issue of warning letters, actually these were harsher means, but we didn't use many of that. And actually there has been an evolution. Now, if you look at the government's regulation of private hospital, since the 1980s there have been a lot of changes, and I call that an evolution. Now, I know that there are a lot of concerns about private hospitals, and there have been a lot of changes about regulating private hospitals. Now we intervene in the administration of private hospitals more and more. But of course, the public can also make their own judgments. And we want to point out that, yes, in the past, we didn't issue many warning letters. However, to a certain extent, we think this has something to do with the loopholes in the law. We think that the relevant piece of legislation has to be updated so that we can strike a better balance. And also in future law enforcement actions, maybe we can rely more on the law, because now in the law it hasn't set out many types of means. It doesn't mean that if we do not amend the law, we cannot do anything, but we really need stronger legal backing. Otherwise, people may accuse us saying that we are too harsh. But if the legal framework is clearer, then I'm sure when it comes to our law enforcement, and if we have to resort to harsher means, I am sure it will be helpful. Thank you. Mr. Chair. Now, Secretary, do you agree that the law allows you to do inspection, and when it comes to license renewal, you also have your authority, and you can set out new conditions when it comes to renewing the license? And also you pointed out that a code of practice has been in place ever since 2003. So in the law, it is very clear that you can do certain things, but it seems that you are not doing it. So it would leave people with the impression that doctors are protecting or defending doctors. Secretary, when you answer the question, can you be more focused? Because if you look at it from such a microscopic point of view, then it will be very difficult for us to write the report. Because we are now doing a fact-finding exercise, so please be more focused. I would like to thank the Chairman for his reminder. Yes, I will try to adhere to the Chairman's reminder. Now, in the law, yes, as Mr. Chair pointed out just now, the Department of Health can refuse to renew the license of a private hospital. As to whether there's a revocation of license clause in the relevant law, I would have to check again. But there are different ways of handling private hospital matters. And for example, the issue of warning letters, etc., I admit that we didn't do enough in the past. But it also reflects that the legal framework is not too detailed. Now, if you say that the law allows us to refuse to renew the license, you have to understand this. That is, for a hospital, the suspension of a license is not such a simple thing. It will have a huge impact on the patients. So I hope that the future legal framework would allow us to do different things. There should be different levels of censure, so that we can work with a proper legal backing, and we can penalize the hospitals at different levels. Well, Chairman, the Secretary said just now in his opening speech that ever since the year 2000, people have been very concerned about sustainability. That's because of the economic downturn, and people were not doing good business. So at that time, there was no regulation. And over the past few years, we understand that there have been a lot of problems with private hospitals. For example, mainland mothers giving birth to babies in these private hospitals. And now the Secretary says that it's not the opportune time to regulate them. So when will that opportune time come? Well, Mr. Chair, I do not have comments on the first part of your views. However, about the second part, we have adopted a very different attitude now. Now, in particular, with this audit report, and after listening to members' views, I myself think, well, actually, I think that the DH would agree with me. That is, at this moment, we should have an overhaul of the relevant piece of legislation, and we should give the DH more resources so that we can do a better law enforcement job. Now, I would like to remind the Secretary that now we are using the same piece of legislation as the one we had in the year 2000. So for things you could have done then, you can do it now. I'll give you 1 more minute, Mr. Chair. Well, the Secretary explained to us that, yes, the inspection of hospital is a very complicated matter, and you have to understand different specialty areas in order to do that thoroughly. We understand the DH as a checklist for inspection. And between 2011 and 2012, well, for some certain reasons, the relevant inspection team has stopped using that checklist, and the relevant records were not that detailed. The Secretary says that the inspection is very complicated, but how come they are not using the checklist? It's quite contradictory. And also for suspension or revocation of a license, of course, is a very serious matter. But there are many choices between not doing anything and the suspension of license. Now, how about warning letters? Under what circumstances would you issue an advisory letter, and under what circumstances would you issue a warning letter? Now, this should be a time-honored system, but it seems that the administration has not followed the relevant guidelines for issuing such letters. Secretary? Well, I would like to answer the second question first. I have already forgotten the first question. Now, for the letters, yes, I agree with Mr. Chair. Well, actually, I said it earlier already. We should make better use of these kind of middle-of-the-road methods. Now, the audit has pointed out directions for us, and we will be setting standards according to different levels of severity. Under certain circumstances, we will issue advisory letters, and under other circumstances, we will issue warning letters. So how about the first question? I would ask the Director of Health to explain. Director of Health, please. I would like to thank Mr. Chair for his question. Now, for the Department of Health, no, you don't have to thank them. You can just answer the questions. Yeah, you don't have to be that polite. Now, when it comes to inspection, we have a guideline or protocol, and that has already been given to private hospitals beforehand, so they know exactly what they need to do, and they would have to fill out an inspection report, and it's like a questionnaire. They have to fill in everything, for example, the management policies, the facilities in different departments, and all sorts of enforcements, etc. So a lot of details in there. So after looking at the questionnaire at a meeting, then the whole team would sit together and come up with an inspection framework. For example, our chief medical officer, senior nurse, hospital officer, etc. They will be divided into 3 teams, and then they will do the inspection, and after the inspection, a report will be written. As for the checklist, yes, there has been a checklist all the time. However, for the frontline enforcers, according to their years of experiences, they think that the checklist may not be the best tool. So in 2010, they adopted a new method. That is, they didn't use the checklist. They just work in accordance with the guidelines. So after inspecting different departments, they would come back to write the reports. Yes, I agree with Audit. That is, we will use the checklist again, and we will include the comments made by the Audit. Mr. Wang Yueman, Chairman, I do not intend to be polite. I would like to say this to the Secretary. Now, you're a newcomer, you have to understand what PAC does. For oral questions and motions, well, secretaries always love to give us lengthy answers. But now we want you to answer factual questions. Just now the chairman has already reminded you. And members have been instructed not to make too many personal comments or make a long speech here, because time is limited. Thank you, Mr. Wang. Now we have studied the whole report. Audit has pointed out a lot of issues. For example, the inspection guidelines, regulatory matters, and also follow up on the announcement of Centennial events, etc. And also price transparency, etc. So for all these, Audit has put forward a lot of comments. So after studying this report, I think there is a crucial point. Now, when you answer members' questions, I wonder if you would agree with me. That is, for this code of practice is not legally binding. And the private hospitals do not have to comply with it. So if the code of practice is violated and you tell us that these hospitals are your partners, you are the law enforcement agency, and at the same time you say they are your partners, and you also mention the hawker control teams. Well, I get very angry when I talk about the hawker control teams, because they have thrown away the belongings of street sleepers, because they cited a wrong example. Well, we are not a law enforcement agency, so please ask your question, Mr. Wang. Now, you're saying that they are your partners. So that's why the Bureau has not been too severe with the hospitals that have violated the code of practice. So, first of all, do you agree with me on this point? That is, I think there is this core point in the Audit's report. The COP is not legally binding, and you have not made much effort in enforcing the COP. Okay, you can, Dr. Koh, you can answer Mr. Wang's questions. Yes, I agree with Mr. Wang on the first 2 points. However, for the third point, I think we can just try to work harder. But I would like to reiterate the point. Well, I don't want to cite many examples. However, I want to say that when we enforce the law, we really need to strike a balance. Mr. Wang, just now some members mentioned that the piece of legislation was enacted in 1963, and then in 1966 there was an overhaul. But now we are still using this piece of legislation, which was amended in 1966. That is the Private Hospital Nursing Homes and Maternity Homes Registration Ordinance. Now, I would like to ask the Secretary, have you set in your timetable a date for amending the ordinance? Yes. And when will that be? Well, there is something under my control. That is to review the ordinance. And then we will make recommendations on amending the ordinance. And that will take about a year. But we have to do public consultation, and then there will be legislative procedures. So these are not under my control. Mr. Wong, so you really don't know how long the consultation and the legislative procedures will last, right? Well, please let me call your name first before you answer. Well, my question is, well, in the second part of his answer, that is when it comes to consultation and legislation, he really cannot control the time. Yes, I think time to be spent on those areas cannot be controlled by me. But you would have an estimation, right? Secretary? Well, from consultation to legislation, well, because this is a very complicated issue, it may take at least 2 years. Mr. Wong? We have been studying this audit report, and the second part is about inspection, and part 2 is about inspection of private hospitals. So for the Office for Registration of Healthcare Institutions, the audit report has pointed out a number of mistakes about inspection reports. Now, for these mistakes, they have reflected that the relevant bureau has not done enough. Well, can the question be repeated? Mr. Wong, can you repeat the question? Now, in part 2 of this report, it shows that the ORHI has made a number of mistakes when it comes to inspection reports. For example, it has not used a checklist to record the inspection findings, and there has been no proper documentation, so the reviewers are not sure about problematic areas. I'm not citing these because I was not citing this because I wanted to save time, but for all these mistakes, it shows that the Department of Health has not done enough when it comes to regulating private hospitals. As to whether these are mistakes, well, I actually cannot agree with Mr. Wong. Yes, some things have not been done, and would that hamper our law enforcement efforts? Yes, I agree with that. I think it is definitely a mistake. Later on, we'll decide on that because that will be recorded. Now, for this kind of mistake, well, the Secretary says that he does not agree that this is a mistake. I think this has really undermined the Department of Health's enforcement effort. Yes, Secretary, if you do not agree with our member, you can explain to us because we are trying to find the facts. Well, tell us the reasons.
You don't agree that these are mistakes? So I'll let him answer first. Secretary. I want to clarify this. I just say that I will not comment on the use of the word mistakes. Well, you will not comment on mistakes? No, I'm asking if he agrees to what I say. I reiterate, Chairman and Mr. Wong, I agree that for the 3 practices pointed out by Mr. Wong, it would lead to, or it would affect our ability in enforcing the law. I agree with that, but I won't comment on the use of the word mistakes. Well, my next question is for the Director of Health. Now, in relation to the DH processing of applications for registration or re-registration of private hospitals, what are your considerations? That is to say, for the problems arising from a full inspection report of private hospitals, will that be one of your considerations in processing the registration or re-registration of hospitals? Now, according to 2.11, well, there were 116 inspections, out of which 40 were recorded, and B, ad hoc inspection, 31 were recorded, follow-up inspection in C. Well, some investigations had to do with the overall review of electricity supply, and we also engaged the relevant professional staff in this regard. So we did not compile a report per inspection. We compiled a consolidated report in relation to these inspections. Now, 9 inspections had the reports compiled. For some others, they were in the file minutes, and in fact, we have this information. But in terms of the consolidated report, we agree with the audit recommendations that we should standardize it so as to facilitate the inspection program. Now, as for the factors mentioned by Mr. Wong, we will take them into consideration. Mr. Wong, the lack of a comprehensive inspection report will make the monitoring authorities like LegCo not being able to ascertain whether the department has exercised effective monitoring with the use of the COP. Now, the purpose of the review is that if we go ahead with amending the legislation, we will step up the relevant regulatory law. Mr. Wong, so you're responding to what I said just now. That is, you agree that the lack of a full inspection report will cause the relevant monitoring bodies, such as the Audit Commission or LegCo, unable to ascertain whether effective monitoring has been done with the use of the COP, which has no legal, no binding effect. Secretary. Well, to supplement this answer, there was no official report for these inspections, but there were records, and I feel that to a certain extent, those records would allow the enforcement department to follow up on matters that require follow-up action. Mr. Wong. Now, my final question is that after reading the report, basically we agree with the audit recommendations. In 2.16 of the report, the DH agrees that a suitable checklist and a standardized inspection report will be introduced. So I hope that the DH can answer my question. On the introduction of a suitable checklist and standardized inspection report, can you give me a timetable for its implementation? Director? Now, for the updated checklist, after the release of the audit report, we have adopted this new checklist. We have also referred the checklist to the Director of Audit for the reference. And the inspections conducted this year is for the registration or re-registration of hospitals next year. Mr. Ng. Thank you, Chairman. Now, I'd like to say more about 2.6 Table 1, about the inspections conducted over the past 3 years and on how the COP could be improved in the future. C. Follow-up inspection. In 2009 and 2010, the number is 0. In 2011, there were 23 follow-up inspections. Does it mean that for the inspections conducted in 2009 and 2010, the numbers were 0 because of inadequate documentation and that no follow-up inspections could be conducted? Because according to the definition, follow-up inspection means that when necessary, the DH will conduct follow-up inspections of selected private hospitals to ensure that irregularities detected during annual or ad hoc inspections are rectified. Secretary, oh no, please allow me to continue. Is it because of the inadequate documentation that the department had not been able to carry out follow-up inspection? Or was it the case that after the first 2 inspections, you found that there was no need to conduct follow-up inspections? And for the 23 follow-up inspections in 2011, all had to do with the review of electricity supply. Is it the case that all 23 inspections had to do with electricity supply? Director? Well, let me explain about this table. For annual inspection, basically it took place in the second half of every year. And after inspections, we would deal with the licensing. But after annual inspections, very often follow-up action would be required. And therefore, during the ad hoc inspection in the first quarter of the following year, this will be done. And during the ad hoc inspections, the matters to be followed up from the annual inspections will be taken. So it's not the case of a lack of documentation that no follow-up inspection was required. It's the case that we would follow up on matters that require follow-up action from the annual inspections. As for the 23 inspections in 2011, it had to do with the electricity supply, so we checked all private hospitals together with the EMS staff. It was a thematic inspection for that year. Mr. Ng. Now, according to what you said just now, there was no follow-up inspection because everything had been fixed during the ad hoc inspections. Then, according to the Audit Commission, the audit commented that a checklist was not used for inspections. So, the findings of inspection were not documented. And, for example, for the thematic inspection in the follow-up action in 2011, it was not documented. So the initial findings of the audit does it mean that what I said is correct? That is, there was no need for follow-up inspection. But the checklist is a tool for inspections so that we can check things item by item. And after the inspections, we do have an inspection report which sets out the inadequacies and shortcomings, and we will then have a meeting with the private hospitals to urge them to improve. So we have an updated checklist, we have improved, but it's not the tool that counts. It's what happens after the meeting, and after the inspection, and that is the meeting with the private hospitals, and we would urge the management to improve. The Secretary also said that there is no report. But like I said just now, for all the inspections, we did have a report. For example, the consolidated report for the 23 follow-up inspections under C in 2011. As for D, inspection for matters relating to registration, I mean, some of the findings were included in the report, some were included in 5 minutes. And apart from inspection reports, under other items, we also carried out inspection. For example, under E, inspection of complaints. According to 2.9, the audit made an inquiry, and in September 2012, you replied to Audit in relation to relevant sections and clauses of the COP and the inspections carried out. And it says here, the absence of proper documentation may limit the reviewing officer's ability to ensure that the frontline staff have properly identified all cases of non-compliance with the COP. So be it the report that you mentioned or the follow-up inspection, according to which report a report was compiled, are they sufficient in ensuring that the frontline staff have properly identified all cases of non-compliance and that follow-up action was required? Does it mean that you did not have proper documentation? Now, for the checklist, as I replied in the previous question, we did have a checklist. We did keep it in a file, and the audit checked through our files and found that we had not been using the checklist for the past 2 years. That's because for the staff concerned with their ample experience over the years, they felt that it was not the most appropriate method to use the checklist. But upon the audit's recommendation, we have resumed the use of checklists. And it's not just a list of check boxes. We would ask the medical staff on the spot questions. So it's not just a list of hardware. Focus should be placed on the inspection officer's report. Listen. Now, I have 2 conclusions. Initially, I'd like you to confirm it. First, is the COP sufficient? Can the COP sufficiently guide you to prepare a checklist? If not, then will you prepare proper checklists in the future? Second, over the past 2 years, in terms of monitoring of private hospitals, you had not been able to ask inspection officers to make use of the inspection checklist so that there is proper documentation. Director, the checklist is based on the COP. I mean, the items contained in the checklist are those contained in the COP. And officers would conduct inspections item by item. For the checklist that was suspended temporarily, it would not affect the actual inspection because we had an inspection team of a few officers, and after the inspections were carried out, they would sit down and compile a report together. The report would be a very detailed one, and the private hospitals were also required to fill in a long questionnaire. They would be required to answer the questions, and beforehand we would have got their questionnaire and the relevant documents first before the inspections were actually carried out. Mr. Ng, then I have this feeling that in the future, a more suitable checklist should be compiled for the purpose of carrying out inspections in the future. However, you said that before the inspections, a lot of preparation work had been done. For example, questionnaires and other documents, which would replace the checklist. So do you agree with the audit recommendations that a suitable checklist should be compiled? Now, for what I said about inspection, that is the method that we have been using for many years. And in the recent years, we had suspended the use of checklists, but we agree with the audit recommendations that inspections could be carried out in a more systematic manner with the use of a checklist. Mr. Ng. Well, if you confirm that a suitable checklist should be compiled for inspections in the future, then that means you agree with the audit recommendations. What I don't understand is that for the previous 2 years, you all of a sudden switched to another method and you didn't find any problem with that. So I'm confused. In terms of monitoring, what happened in between so that the officers could resort to means other than the checklist? Because without this audit report, they could try other means, and if there is no COP, I mean, they may not be following the COP. This COP contains over 100 pages, is a very thick document. So for the practice over the past 2 years, my question is whether it should be rectified, or are you saying that the practice over the past 2 years was correct as well? Director, would you explain why this happened in those 2 years? Director. Well, in terms of the enforcement by frontline staff, we regularly reviewed the methodology. Perhaps in those 2 years, the frontline staff was of the view that they could make reference to other practices. For example, the inspection of hospitals by overseas accreditation bodies. Because we should not just look at the checklist. A checklist only contains items. As for the quality, it's contained in the report, but I emphasize that we take on board the audit recommendation, and that is a suitable checklist would assist the staff in carrying out the work and to keep a proper record afterwards. As far as the inspection itself is concerned, let's say a patient is admitted in a hospital, and we start from that point, and as the patient enters the hospital, he then goes into a ward and so on, and we ask questions in relation to these matters. It's not just about the checklist, it's the discussion that matters. We have a quality discussion with the medical staff secretary. You want to supplement? Yes, just to offer my views. It's not a matter of whether the practice adopted by frontline staff in those 2 years was correct or not. There were professional reasons behind that, because the checklist was not just about ticking boxes. It was interactive, and they tried other methods. But anyway, we agree that it is a better way to have a suitable checklist, so we agree with the audit recommendation. Mr. Ng. One final thing. I want to confirm this. According to the audit report, without proper documentation, be it a checklist or whatever code of practice, it may limit the reviewing officer's ability to ensure that the frontline staff have properly identified all cases of non-compliance with the COP.
跟住去
Will this make it convenient to evaluate the effect or effectiveness of inspection if this is the current method and in the subsequent year another method is adopted? Then there won't be a way to ascertain whether or not inspection has been done effectively. This is my biggest concern. Director or Secretary, if this is your point, then I agree that the method described by Mr. Ng Lang Sing is better. Every time our colleagues conduct inspection according to the code of practice. And in most cases, reports are made. Even without a formal report, there is a record so that we can follow things up. But I will agree that if the records constitute a more formal report, and during inspection, apart from professional, interactive, two-way communication, it will be better if there is a checklist. So on this basis, we agree to the audit, to the Director of Audit's recommendation. I would like to follow up. In your introductory remarks, you said that inspection is very complicated. So in 2009 and 2010, well, of course, we know that these are experts. And they came up with a new recommendation. Do you think the work done in those 2 years is better or not? We're talking about records, checklist, and these are two different things. These are different from the quality of inspection. The Director of Audit has brought up this point, and you have accepted his recommendation. So you have accepted the Director of Audit's complaint. But in fact, the inspection process is a very complicated one. Can you elaborate more? It doesn't mean that we will think that you are right or wrong after you accepted the Director of Audit's recommendation. So can you explain further this issue? Thank you. A hospital is a very complicated professional organization. I won't repeat the point about the complexity. Our professional colleagues will consider their past inspection experience, and there is also a code of practice. And hospitals are asked to do some preparation work to provide us with some information. So colleagues may think that even without a checklist, they will still be able to conduct their work. Of course, I cannot do a comparison on whether this is better or not. But we are trying to be objective, and the Director of Audit's view is even more objective. We now think that even with a checklist, you can still conduct a very professional inspection. So on this basis, I think that it will be better. Mr. Chan Hak-kan and then Mr. Alan Leung. If there are breaches by private hospitals, the Director of the Department of Health will issue warning letters. And in the report, para 2.21, sometimes the private hospitals may not be able to differentiate advisory or warning letters. Private hospitals may think that advisory letters are just ordinary correspondences. And the Director of Audit said that they may not be able to differentiate. So I would like a confirmation as to whether this is true. And when private hospitals receive advisory or warning letters, they may not think that it's a big deal. They may not know that these are advisory or warning letters. Is this a very common scenario? Secretary, Chairman, I will speak first, and perhaps later the director can supplement. If you read the text of the letter, if you want to convey a message, then there may be an issue of understanding. The Director of Audit is of the view that if the nature of the letter is spelled out in the title, then I think the recipient will be able to understand the content not only based on the wording or the text. And colleagues are confident that the letter will be good enough to convey the message. But we agree that if in the letterhead it is spelled out clearly that whether this is an advisory or warning letter, then it is clearer to the recipient. Mr. Chen? If the Secretary agrees with the Audit Commission, now every time after inspection is made by the Department of Health, they will issue a report to the private hospitals. And if there are breaches or inappropriate conduct, then we don't know whether or not the private hospitals will follow things up. And will the Department of Health know? Will they review whether or not the private hospitals have followed things up or whether they have rectified the situation? After letters are issued, do you normally check whether the issues are resolved? Director, can you please confirm whether there is a report after inspection? So sometimes there's oral report, and can you clarify? Thank you, Mr. Chen. We do have a written inspection report. It is a record. No matter whether it takes the form of a letter or whether we will just list out all the inadequacies in the report, we will let the private hospitals read the report. We will follow things up so that they know what kind of inadequacies are there. And then in relation to advisory and warning letters, we also follow things up. And usually a few months after the inspection or special inspection, we will inspect again all those unsatisfactory areas. Chairman, they said that they will follow up on the inadequacies, but if I read 2.27 and 2.28, case 1, there's a case admitting maternity cases to non-maternity wards. This is surely an incompliance of the Code of Practice. The Department of Health issued 2 advisory letters, but still the hospital turned a blind eye to the advisory letter. You said that you followed things up. You wanted to make sure that things are rectified. But then in this case, there were repeated breaches of the code. And the time, the duration involved was 9 months. Every month when they admitted 100 patients, but there are only 25 maternity beds. So how can you say that you have followed things up? Can you explain, Director? Referring to case 1 on page 16, the private hospital, during our inspection, in the postnatal ward, patients were admitted to surgery wards. So this is not in the area of the maternity department. We asked them to improve. At that time, there were enough nurses, but in terms of midwives, there is not necessarily the case that there is one midwife in each postnatal ward. And we understand that pregnant women have to make appointments a few months in advance. We understand that if we ask them to terminate this approach, the pregnant patients will be affected. We do know that they had enough nurses, and it took a period of time for them to comply with our requirements. So when their license was renewed, there was an additional condition. We said that we would only renew their license if they're able to meet all the conditions within a specified time period. And before the deadline, they notified us, and we checked, we inspected the situation, and we gave them the approval to increase the number of maternity beds from 25 to 35. We do think that the hospital is not right in this case, but concerning safety of the mother after giving birth, we allow them to continue their operation, but we ask them to improve the situation before we granted approval for them to increase the number of maternity beds. This is an exceptional case, but the report doesn't mention other cases. Now, Secretary, Director, I think that there are cases of repeated breaches by private hospitals. If they receive warning letters, they turn a blind eye, or if you just don't regulate the situation, then is this acceptable to the Bureau or Department? Director? Chairman, we will consider the nature of each and every case. Apart from the case about maternity cases, there are cases in which the power system is not adequate in private hospitals, and we ask them to update the system before we renew their license. In some hospitals, in some units, when the upgrading is not completed, we didn't allow them to continue operating that unit. These are simple cases or mild cases in which there are not enough beds, so things may be acceptable. But in some cases, if there is serious breach by private hospitals, if they did not rectify the situation within reasonable period, should the Bureau or Department consider raising the level of severity of warning letter or advisory letter? It seems that there is no standard. Sometimes you ask them to rectify, sometimes you issue advisory letter or warning letter. So when will you give oral warning, and when will you issue advisory letter or warning letter? When are you going to use your trump card to revoke license? If there is no criterion in the government, then in cases of breach by private hospitals, there may be different law enforcement action in similar breaches or cases. Secretary or Director? Secretary, this involves future arrangements. I can say very clearly that in the future, well, this may not be easy. You have to exhaust all possible scenarios. This may not be possible. However, if we summarize different types of breaches, and then we spell out the corresponding actions to be taken, I think this is the future way forward. Mr. Chen, any other questions? No. Thank you. Alan? Thank you, Chairman. Up to this moment of the hearing, I think the 6 witnesses in attendance will understand. I will not debate with the Secretary as to whether the situation will be better after enacting a law. But Secretary, if you review how questions are being put to you, under Cap 165, you do have the power. So there is no question that you are not able to improve your work to better protect patients patronizing private hospitals. It's just that you have not really done your work completely. So it is not a matter of a lack of ability. It's a matter of not doing it. So usually in different stages, I will let witnesses know my views in different stages. Only this will be fair to them. Because after the hearing is concluded, we cannot ask for further evidence under the same circumstances. So I would like the Secretary or witnesses will answer my following questions with this mindset. Referring to Cap 165, Secretary, do you agree that you do have the power to lay down registration conditions? And then in the hospitals or maternal homes, when they ask for re-registration or renewal of registration, you can exercise your power to test whether they have satisfied the conditions laid down. The most powerful tool is not to register them. At the same time, you do have the power to exercise your power under Cap 165 Section 6. The director can make rules on the following items. And then according to 6(2), you can ask the CE in council to, for example, pass on penalties like fines, or you can also make rules that involve criminal offenses. So your power is not small. Chairman, I would like to follow up on points asked by other colleagues, but I'd just like to offer another opportunity for the Secretary to answer, to see whether he has really enforced Cap 165. Concerning the inspection checklist in the Director of Audit's report. Wait a moment, Chairman. Let me turn to that page. In para 2.7 and 2.8, it is stated clearly that in 2009 and 2010, during inspections, the checklist was used. Thanks to the Bureau and Director that the COP had been provided for us, and there are 109 pages, 34 chapters, without including the appendices. This is a very complicated document. You inspect so many private hospitals and maternal homes. If there is not an objective standard to enable you to follow up, or in the future, if you want to revoke the license or fine the hospital, there must be a basis. So my first question is, after working for 2 years, the chairman had asked you repeatedly to compare those 2 years with the years in which the checklist was not used. Now, in 2011 to 2012, the checklist was not used. And Secretary, Director, if you compare the situation in which whether or not the checklist was used, well, with the checklist, that would be objective standard, and you cannot even easily differentiate advisory letter and warning letter.
And then in point 2.17, Audit also mentions the guidelines, and advisory letters are very different from warning letters. For example, for advisory letters, it's about non-compliance with established policies and procedural guidelines, inadequacies that require prompt rectification or improvements. But for warning letters, it's about accommodation, staffing, and equipment. So after the warning, you can also add conditions when it comes to the license renewal. And also under paragraph 2.18, it says that you can take criminal action, and also the license can be revoked. But if you do not have a set of objective purposes, then how can you inspect objectively? For example, if it's a doctor or a nurse or an administrator that's doing the job, well, actually, that's quite different now, because there are 11 members in a team, and A would go to a certain hospital and B would go to another hospital. So if there is not a set of objective rules, then how can you do things properly? And if you're saying that if you want to add conditions when it comes to license renewal, then you will be challenged. You would say that I have already issued a number of warning letters and advisory letters, and you ignore me. And that's different, because you have justifications. So if you haven't done that, then you don't have those justifications. So my conclusion at the moment is that you have not seriously enforced the law at the moment. That is the power given to you under Cap 165. And you tend to be too lenient, and it seems that you are turning a blind eye to some issues. So if you do not agree to my conclusion at the moment, maybe you should seize this opportunity to persuade me or convince me. Now, there are two types of letters, but there is no clear differentiation between the two. And for the past years, there has been no prosecution and no revocation of license. So are these not evidences proving that you have not exercised your power given to you by Cap 165? And also, Mr. Chang can also cite an example. Well, Mr. Leung, can you let the Secretary answer the questions first, because these are very important questions concerning the whole concept. Well, I've heard two questions. I'll try to answer these questions first. First of all, for Mr. Leung's first question, it seems that when it comes to law enforcement on our part, we have not been too serious. Now, just now, the Director of Health has been explaining to you, that is about the professional attitudes of our colleagues, and when a decision is made, whether we think it's right or not, well, she has been trying to make improvements. And the Bureau, well, as to whether there's enough manpower, of course, that's another issue, but we are beefing up our manpower so that we can enforce the law in a better manner. So I don't agree that we have too relaxed an attitude when it comes to law enforcement. As to whether we have fully enforced the law, yes, we may not have done that. Well, as to whether we have exercised all the powers given to us by Cap 165, well, actually, the Director pointed out just now we have invoked certain provisions of the ordinance. That is, we would add certain conditions when it comes to license renewal. And if these conditions are not satisfied, then we will not renew the license, or we would not approve the request for increasing the number of beds in maternity wards, etc. So we have exercised our power, but have we fully exercised our power? That's another question. Now, if you say that we have not fully exercised our power, I may agree to that. Now, why do we have to improve our laws all the time? Because when there is a piece of legislation there, sometimes it may not be detailed enough. Then not all our legal actions can have strong legal backings. And sometimes, if it's like this, it will be very difficult for us to enforce the law. Mr. Leung, has he answered your questions? Chairman, well, maybe I didn't ask my questions too clearly, so I would like to ask again. Now, the focus is that now, if you want to exercise the power given to you by Cap 165 concerning the regulatory control of private hospitals, then you should have objective ways to collect evidence. And you must have a set of objective targets so that your law enforcement efforts would not be challenged. But if you don't even have a checklist, then you do not have this foundation to work on. Yes, from time to time you will enforce the law and you would issue letters. But this is not a system. And without a system, you cannot be firm. Because when a private hospital challenges you, now for example, if you lay down new conditions upon the renewal of license, or even you want to revoke the license, then you cannot come up with a set of clear records so that everybody would know that the hospital has done so many things wrong that it deserved it. Now, when I look at the audit report, it seems that the OLHI has not put together such a system so that when you exercise the power under Cap 165, you would have something to rely on. Then I would say that you don't really mean to exercise your power under Cap 165. That's why you have not put together a system or a set of targets. So can the Secretary try to convince me that this conclusion is not necessarily right and there can be other conclusions? And I can put those in my report. Now, for those objective benchmarks, whether objective benchmarks are given to private hospitals so that when I enforce the law in the future, things can be clearer. Well, actually, I don't agree with you because the guideline is the foundation. So most of the time we would use guidelines to tell our regulatees what our requirements are. And if they cannot comply with those guidelines, then that's the reason for my loss enforcement. But for the checklist, I agree that that is an improvement. Well, that would allow our staff to have a clearer guideline, but it doesn't mean that it's definitely the foundation for our law enforcement. Now, for law enforcement, well, I have to tell the regulator what I require, and if I can objectively prove that there is no compliance, then of course that is one way of doing it. But we can build up cases, and actually the DH has already done that. Now, when we inspect the hospitals, if there are problematic areas, then we would point them out to the hospitals. For example, we issue them regulatory letters, and after that, if they do not make any improvements, then that's already a foundation now, because we have already told the regulator, there are objective standards, and we do the inspection and we see non-compliance. We've already told them that they should make improvements. I've already said that. And if they do not take any action to make improvements, then I already have the reason to take legal action. So the DH already has objective benchmarks, and the private hospitals know about them. If there are non-compliance, we will tell them. Of course, we can always have a more systematic method, I agree. But now we do have a system. We would notify the hospitals that there's something wrong and they should make improvement, etc. Director, I would like to supplement. For the inspection, it's very systematic. There is a code of practice, and then before the inspection, we will ask the hospital to fill in a very detailed questionnaire, and we would look at every single item in the questionnaire concerning different specialties, facilities, professional staffing, equipment, licenses, etc. So all these details are in the questionnaire. And when we do the inspection, we also have a protocol for inspection. That's for our law enforcers. That is, each year in a certain month, we will start to plan for the inspection framework, and then we will divide the team up into different groups, and they will look at different things in the hospital. So that's the annual inspection. And then there's also a special inspection. The leader would be the chief medical officer, and after the inspection, all the details will be reported to the chief medical officer, and then there will be a meeting, and after that an inspection report will be drafted. So all the small groups will be visiting different parts of hospitals, and then the chief MO will standardize all the findings, and a report will be written. Well, Mr. Leung is giving you an opportunity to explain. After your explanation, we can look at the other parts more easily, because if the inspection is not good, then the result may be complaints and other problems. So Mr. Leung is actually very sincere. He wants you to give a chance to explain clearly so that we can understand the situation better. Mr. Wong Yuk-man, I would like to ask about regulatory actions arising from inspections. Let us look at paragraph 2.17 of the report. And this is about paragraph 2.15a. Now for 2.17, it says that after an annual inspection, the DH will inform the private hospital orally or verbally advise the hospital management on areas that need rectification or improvement. And for annual inspection, the DH will also issue a summary report of inspection which contains its advice and overall assessment to the private hospital for follow-up. So for the annual inspection or ad hoc inspection, the DH will verbally advise the hospital management. So is anything in writing here, or is just a verbal advice? Director? Chairman, Mr. Wong, for the verbal advice, well, after the inspection and after a meeting, there will be an inspection report. And in it, we would say that, well, on site, the certain verbal advices have been given to the hospital. So at the hospital, a verbal advice was given. And then afterwards, it's recorded in the inspection report that a certain verbal advice was given. So why can't it be in writing? Director, yes, I agree that in the future we can do it more systematically so that this kind of advice or warnings can be standardized. Can you give us a report like that so that we will know what that report is like and what that verbal advice is about? So you have this kind of reports. Can you give us a copy? Yes. Mr. Wang, I really cannot accept this. So you are advising the hospital verbally saying that there are certain areas that need rectification or improvement, and that's just done verbally. And you are notifying the hospital management in that way. So how can that be recorded properly? Secretary, according to paragraph 2.17, now the DH inspectors during the inspection would verbally notify the hospital management. But after an annual inspection, the DH will also issue a summary report of inspection. And in the summary report, the views will be included. Now, when we look at the word verbal, you will think that there's no follow-up. Well, but if you give a verbal advice, it would be good because you do that immediately, and that would leave a deeper impression in the staff. I cannot accept this answer. You are trying to play with my rhetoric. Now, I think it is very clear here. Now, for the advisory and warning letters, yes, we know about them. But before that, yeah, you are saying that there will be a summary report which contains its advice and overall assessment. I do not have any misunderstanding here. But I cannot accept that only a verbal advice is given to the hospital management. So what will happen afterwards? Now, if you say that there will be a summary report that will be given to them, then why do you need a verbal advice? And if it's more serious, you will issue advisory or warning letters. We want a complete and clear record. We want a specific record. Now here, you talk about areas that need rectification or improvement. So if you just tell them verbally, what the circumstances are at that time, I think if you do it this way, it is not professional enough. And also, I'm very concerned about the DH issue of advisory or warning letter. Just now we talked about the differences between advisory and warning letters, and I'm not going to dwell on that. But in 2011, the number of advisory and warning letters has increased significantly, and that has not included verbal advices. So for verbal advice, it will be included in the summary reports later. So for the verbal advice, in 2011, how many were there? You have records, right? So how many verbal advices have been given in the year 2011? Well, that will be in the inspection reports. I do not have the total number with me at the moment. I will give that to you later. Well, we really have to answer this question, Chairman, you see.
In paragraph 2.20, the various irregularities were found during inspections, and the DH issued 6 advisory warning letters to 6 private hospitals. However, 8 reasons were set out in para 2.20, and my question is, can you tell us, now in relation to these 6 private hospitals, some of them had more than one irregularity, probably all 8 irregularities. Do you have this figure? Yes, we do have the figures. We keep a record of the number of warning letters issued per year and the content of the warning letters. We can provide this information in a table form after the meeting. All right, moving on to para 2.22. The DH had failed to issue advisory or warning letters against some of the serious irregularities. For example, specialty center in operation before registration of the premises, that's number 1. Fridges for storing drugs and vaccines not being regularly maintained, that's number 2. And number 3, issues relating to the Chinese medicine service. And D, medication management. Chairman, my question for the director is, if these irregularities were committed by public hospitals, what would the department do? Is it the case that a different standard was being adopted by the department in relation to private hospitals? Secretary. Management of public hospitals is different from private hospitals. That's true, but if you talk about professional management, we do not have 2 systems. I mean, we have different management systems. Chairman, I said very clearly, now, in para 2.22, some serious irregularities against which the DH had failed to provide, had issued advisory or warning letters. I quoted 4 examples, but Secretary replied by saying that the management systems were different, but the standard was the same. What I'm asking is the specialty center in operation before registration of the premises, the fridges for storing drugs and vaccines not regularly maintained, medication management, and issues relating to the Chinese medicine service. If these irregularities were committed by non-private hospitals, what would you do about them? Director, please. Director, would you like to take the question? Secretary, you can supplement. Before the director answers this question, I wish to point out that the director is not responsible for managing public hospitals. Now, for public hospital services, they have their own program. For example, for a new specialty center that would come into operation, it would have to seek the approval of the management committee of the HA or even the board of directors of HA. And on a macroscopic level, they have a risk management system for public hospitals. So the situation is different. They have different management systems. Director should also answer my question, because my question is, if these serious irregularities were committed by non-private hospitals, what would the department do about it? Well, I take it that the Secretary has answered my question. But this shows that in relation to the monitoring of private hospitals, if you had not even issued any advisory or warning letters, I would like to know what you would do, Director, on these 4 points. For the case in A, at the time, the officer during the inspection pointed it out right away, and the center ceased operation right away, and we agreed that we would issue a warning letter. And since the specialty center suspended this operation right away, and we take on board the audit recommendation, and that in the future we should do it by way of a letter. Can you give us some documents? I'm talking about what we would do in the future. In relation to the documentation of case A, please give us the information. As for B, fridges, the DH provided a summary report of inspection, and that's the inspection report I mentioned. That is, after the inspection, our officer compiled a summary report of inspection, setting out the inadequacies, and the report was then passed on to the hospital, and we did not issue a warning letter. As for the case in C, again, the DH compiled a summary report of inspection after a verbal advice given on the spot, and the report was then passed on to the hospital for follow-up action. Similarly, in D, we gave advice to the hospital in the form of a summary report of inspection. But in the future, we will adopt a standardized approach by issuing letters to the hospitals. That is, we will give verbal advice on the spot, write a summary report of inspection to the hospital so that they had the advice in text in written form. Yes, please give us the summary report later. Thank you for the more detailed reply. Now, I move on to questions relating to monitoring of sentinel events and complaints. Perhaps I'll let Mr. Ng Sing to ask his question first. I'd like to follow up on Mr. Wang Yuman's question. Because apart from individual hospitals, you also need to let other private hospitals know about these things and let them learn about this. Because the incident might only happen to one hospital, but as far as CAP 165 is concerned, I mean, your inspection team also had the responsibility of sharing this information with other private hospitals. So we will be following this line of questions, Director. Next, Mr. Ng Sing. Oh, I want to ask Alan. Would you like to draw a line here? I mean, does any other member wish to ask questions in this area because you're the lead member? I will have some follow-up questions on this area first. I think we covered most of the questions. So, all right, I will queue up for the third round. I'd like to ask about the other area. Mr. Ng Sing. My question is on this part. Thank you, Chairman. Advisory or warning letter. Well, we'd like to know how these letters will be issued. Coming back to 2.22, I'm somewhat puzzled by this case. 2.22. In May, the Specialty Center notified the DH that it would be relocated. Does it mean that the services provided by the Specialty Center would be relocated? There had not been any addition or reduction in services. There had not been any addition or reduction of equipment and facilities. And therefore, they thought that after relocation, they could resume the operation at a different location, and only notification was required. And about your way of handling this notification, I'm puzzled. Was it the case that you thought that inspection was necessary because you thought there might be additional equipment, etc., and then on inspection you found that it had not been registered in accordance with the ordinance, and that was a major issue because it might be operating not in accordance with the license or not in accordance with the monitoring regime. So when you followed up on this incident, had you checked for how long had it been relocated and how many cases had been handled by the Specialty Center which had fallen outside the scope or which had fallen outside your monitoring regime? So how many cases were involved, how many patients were involved, and how much money was involved. And on your verbal advice, the center stopped its operation immediately. And again, that was serious. And services for the related patients were affected. And that is a very serious problem. We are very concerned about the efficiency, because in June you conducted the inspection, and then on the 30th of August, in August you conducted the inspection, and then on the 30th you issued a letter attaching a certificate of registration. So that seemed to me that the department was being very efficient. And then the specialty center was generally reminded that DH approval was necessary. So should this case be made a precedent so that the public would know about it? Because everything seemed to happen very hastily. It could cease operation at once, and then a letter could be issued to the center very quickly. So can you confirm and explain about this? Because I'll be coming on to 2.26 and the other point. Let her answer first, all right? This is a rather long question, Director. Thank you, Mr. Ng. For the case in 2.22a, according to the registration ordinance, any change to a hospital, for example, expansion or addition of a specialty unit or relocation of some of the services to another location from the hospital, or to the setting up of a satellite clinic, should be subject to the conditions imposed in the license, so that the location is regarded as hospital premises. And for this specialty center, it had been relocated to a commercial building for operation. So be it expansion, relocation, or addition of services, and relocation to another premises, our approval was required. But on inspection, after being notified, we found that the center was already in operation. It was for outpatients. Although there was a surgical unit in the center, we saw that there was an outpatient specialist clinic for patients. Officers pointed out there and then that this was not permitted, and they ceased operation at once. So it wasn't the case that they had new equipments that had been used without our approval. And they ceased operation once we informed them on the spot. And having received the application for registration, normally after an inspection, after we checked the equipments and staff accommodation and equipment, and after we considered it appropriate, we went through the procedure and informed them that they could commence operation. Mr. Ng, I believe that the case did not involve many affected parties, and therefore you issued a letter for their commencement very quickly. However, we still need to follow it up, because the specialty center was in operation in contrary to the ordinance. So I think that the simple advice would not suffice. You should step up your enforcement, because it had already fallen outside the scope. But What you did was a verbal advice and a reminder, and to take remedial action very quickly to assist them. It's unknown to us how many cases were involved before its registration, and that's against the law. How much money in turnover was involved, how many patients were involved, because the specialty center might come into operation first, and then the letter would be supplemented a few months later. And you talked about the questionnaire, so on and so forth. But for this one, no questionnaire was needed. Only the notification was needed. So in short, I hope that person to this case, to a certain extent, you should set down guidelines to handle cases involving units or centers coming into operation before registration. Now, towards the end of 2.26, in relation to some steps, the DH has not taken the drastic step of cancelling the registration or refusing the re-registration of a private hospital, because when the incident was serious, adequately drastic steps should be taken, but no prosecution had ever been initiated. Is it the case that you wanted to adopt a lenient approach or a lax approach, or were there other reasons for not exercising the power stringently? And it seems that as far as enhanced enforcement action or stepping up of action is concerned, the audit's recommendation is that it's not sufficient, because you need to have sufficient deterrence. So is it the case that under the existing regulatory regime, you have not been able to step up your regulatory action because of the constraints of the ordinance, or what, Secretary? Now, as far as the evidence is concerned, the Department of Health has strived to enforce legislation. But in terms of individual cases, it might be a technical breach. So on advice, they immediately ceased operation, and thereby the patient's interests were protected. However, I also believe that we should have a mechanism under which we can step up our regulatory action or sanctioning, depending on the severity of incidents. So, basically, if the administration takes on board the audit recommendation, I think that under the existing ordinance, you can build up a sanctioning mechanism, but you need to look into it further. I agree that we should try to achieve this under the existing law, and in future, if there are amendments to the legislation, I hope that this mechanism can be incorporated. Mr. Allen Leung, after your question, can we take a 10-minute break? Before you ask the question, I'd like to ask Secretary a follow-up question. Now, just now, Mr. Mong-Yuk-man and Mr. Kenneth Leung asked some questions, and the ICAC report, you were accused of using a partnership approach.
And you cannot balance that with the need to regulate them. And with the partnership approach, perhaps you're not able to discharge your responsibility as a regulator. In your introductory remarks, you said clearly that in the 90s and in the year 2000, they faced many difficulties. And they said that the room for survival would be stifled if you were too stringent in your regulation. And Mr. Potter just asked you, how can you strike a balance? They might face difficulties, but patients' interests cannot be compromised. They should either not do it or they should work like the public hospitals. You cannot say that patients patronizing private hospitals won't need to be protected, unlike in public hospitals. So I would like to give you this opportunity to explain, because you haven't answered our questions. Rather, you have led to even more questions. So I would like you to answer this question in a few minutes. Chairman, I need to point out that to a certain extent, our target of regulation, i.e., our patients, they should enjoy higher service quality. And in relation to law enforcement, we emphasize safety and protection. Both things are important. So to a certain extent, we cannot avoid having a partnership relationship so that the private medical system will be like international medical system, that we can keep pace with time. And please allow me to point out that all along, we have asked private hospitals to complete internationally recognized accreditation so that their operations and professionalism can be enhanced. In our society, there are more and more concerns on operation of private hospitals. So I believe that it is just inevitable that the balance will be moved towards our role as a regulator. Secretary, it seems that you are protecting the private hospitals and you have not enforced the law properly. You want to give them some room for survival. And so it seems that you have been too relaxed to the private hospitals, or you are too lenient to the private hospitals. I wonder whether this reflects the government's mentality, so that you are too lenient in your law enforcement. As a result, patients' interests will be undermined. Chairman, I said that definitely there is a perspective of partnership relationship, but this should not affect our role to protect customers or patients' right to know and their interests. Director, concerning the partnership concept, when our colleague introduced to ICAC our operation, this term was used. In public health care, we always say that we participate with the stakeholders together to protect members of the public. It doesn't mean that we are inappropriately protecting private hospitals. When there are incidents, we will follow things up. Apart from asking private hospitals to do this and that, we will also educate them, and we will also split the burden to other private hospitals. Under Cap 165, there are 3 circumstances where prosecution can take place. Operation without license, and the certificate is not posted in prominent places, or refusal to allow Department of Health officers to inspect. And all along, Department of Health has been working hard to regulate private hospitals and to upgrade their service quality or standard. Apart from promulgating a COP, we have worked with private hospitals to promote the introduction of overseas inspection system so that we can take on board good experience from other countries. Our code of practice is laid down after taking reference from overseas experience. And when we inspect private hospitals, we also carry out our work based on these criteria. Even though we adopt an inspection approach, we did not inappropriately protect the private hospitals. We just want to upgrade service quality with the final goal of protecting final consumers. Mr. Alan Ng, do you want to do a wrap-up? Yes, I hope to do it before we move on to the third session. Concerning the partnership attitude, can I summarize this, the Bureau's understanding of the partnership approach as mentioned by ICAC in their report? Yes, I agree with the director. Okay, then we feel more assured because you have different roles and responsibilities. And, well, to a certain extent, the policemen and the robbers may be considered having a partnership relationship. We are talking about law and order in Hong Kong, but then the police cannot say that if the robbers can be cooperative, then they can be more lenient. This is not acceptable. So this point can be recorded that the Bureau agrees to the ICAC's report dated 2010. If you refer to 2.17 and 2.18 of the report, if there are serious medical incidents and if there are reports, Secretary, do you think that the cases can be directly referred to the Medical Council or the Nursing Board for follow-up? I would like to know the Bureau's attitude. Secretary, as I said in my introductory remarks, if there are serious risks on public health and if there is professional misconduct by the medical professionals or if there are serious breaches, we will directly refer the cases to statutory bodies that regulate professional conduct of these professionals. Okay, so the Bureau agrees to this direction. Good. In your opening remarks, Secretary, you said that the steering committee has 4 working groups. What are the other 3 working groups? Secretary, the first working group works on a medical cosmetic incident that members of the public are highly concerned about. So high-risk medical cosmetic procedure is being examined. So beauty parlors cannot operate or cannot proceed with these procedures without medical doctors' presence. And there may be other high-risk procedures that may not be related to cosmetics. And then when certain establishments handle certain substances on patients' bodies, for example, laboratories. And number 4, there is a working group regulating private hospitals. Secretary, after this hearing, can you provide us with the terms of reference or scope of work of the steering committee? Yes. Secretary, there are a few other things that I would like to follow up on in Chapter 2. Just now, the director said that when private hospitals are inspected, they usually have a questionnaire, but we do not have that. Can you give us a copy, Director? Yes, thank you. And there's a summary report after an inspection. Can you give us a specimen summary report? Just now, Mr. YUEN also asked for that. So you said that you will give it to us. We have already provided that for members. Can you give us the report on Mr. YUEN, on the case mentioned by Mr. YUEN? We just want to check whether that summary report can serve as an adequate basis of law enforcement. Para 2.13. I'm referring to the Chinese version starting from line 4 of 2.13. The Audit Commission has chosen two selected hospitals, and it's revealed that some of their service areas had not been inspected by the ORHI inspection team for 3 years. The Department of Health explained that the service areas had in fact been covered in its inspections in 2011, as indicated in the relevant inspection plans, though this was not documented in the inspection reports. First of all, can you give us the inspection plan? And then here it says that the inspections in 2011 do include the service areas. So what is the basis of this remark? Director, please let us have that document, and then please now answer Mr. Alan Leung's question. Before we conducted an inspection, usually there is an inspection plan, and then the team will allocate work accordingly. So in the inspection plan, those service areas that were not inspected were in the inspection plan. So actually, the team worked according to the inspection plan, but the records did not show that. Our colleagues told us that they did check those service areas, but then they had not checked the relevant boxes. But they confirmed that they had done the inspection according to the inspection plans. Chairman, this is a point which I really don't understand. Your colleagues are very busy. After inspecting a certain hospital, let's say the inspection plans ask them to check items ABC, but there are no items ABC in the report. It starts from D. So this is the basis of the audit's observation. So after listening to the director's answer, you actually rely on your colleagues' oral report that they have checked on certain items. But whether those items are up to standard or not, Director, can you provide us with further information? Director, do you understand the question? I would ask Dr. Chiu to supplement. Well, I was not the one who inspected the hospital that day, but we have checked with our colleagues. According to our understanding, there are a number of items in the inspection plans. They checked the items that they inspected, and perhaps they had missed out certain items. Members asked us for inspection plans. Perhaps we could refer back to those cases to be clearer. Okay, then we can make our observations. There are some other fragmented points. Para 2.14. Chairman, you also asked a question about this some time ago. If we refer to Table 3, there are 6 hospitals, and the Director of Audit found out that, for instance, resuscitation or related equipment, the operating condition, well, they are often problematic, and the fridge for medicines sometimes was not in the right temperature, and the inventory check and so on, or stock taking. So do you have a plan that for problems often identified in some hospitals should also be made known to other hospitals by means of a platform to avoid similar problems in the future? In September 2010, there is a paper on patient safety, and you stated that there are similar arrangements. Has this arrangement been implemented so that this will be done in the future, or is it just a one-time-off exercise? Or is there going to be another platform, or is this the only platform, Secretary? My preliminary view is that this arrangement should be made a standing one, and we will make sure that the Department of Health will act accordingly. Director, we started this approach last year. We'll continue to do it. Can you explain why this approach, why this arrangement was not made in the past? Because this is your responsibility. Usually after inspections, we shared with private hospital our views because we met quite frequently. Talking about patient safety accountability, well, cases could be shared among private hospitals in a detailed manner. We think that this is a good approach. So starting from last year, cases in 2010 were circulated. So every year we will do that. Last 2 points. Concerning case 1, just now Mr. Chen Ha-kun asked a question about case 1, and then the director has made an explanation. Director, in the future, if there is incompliance or non-compliance with the COP, then are you going to lay down a more stringent timetable so that the rectification process won't be excessively long? And what will be the timetable like in your mind? Secretary or Director? Director. Chairman, yes. But we will also consider the nature of each and every case. As I said just now, in some cases, advanced appointments have been made by patients. So if we ask hospitals to terminate certain service, patients will be affected. And with manpower arrangement, a certain number of patients can be admitted. In the future, when we issue warning letter, we will state a deadline, but we will also consider the nature and circumstances of each case. Last point. The last few paragraphs concerning closure. In the audit report, the department has taken on board the Audit Commission's recommendation. When private hospitals are closed down, concerning patient arrangements and arrangement of medical records and also disposal of medical equipment and waste, some guidelines are being compiled. Why is it that there weren't these guidelines in the past? We know which hospital is closed down. So how is that hospital now doing? Referring to 2.31, is the department happy with the arrangement of all these items? And what is your timetable? Director, Chairman. The closure of private hospital is unprecedented. However, when we ask them to make proper arrangements, we have taken reference from legal requirement and patient safety requirements. First, we ordered the hospital to submit a report on closure to the Department of Health before a certain deadline. And we also inspected the hospital. We had a meeting with the management team to have an understanding of their closure arrangements. And we ordered that they could not admit patients after a certain date. And we inspected the hospital to see whether there are enough medical workers, because we're worried that the employees would resign. So we checked their manpower situation. And concerning radiological equipment and disposal of medical waste, we asked that the medical hospital or the private hospital should follow these up one by one in the closure arrangement report. The hospital has been closed down, and then they have handed back the hospital to the landlord. We have complied with the COP. We attach particular importance to patient safety. We inspected the manpower condition to ascertain that patients can be admitted. But in the case if after the hospital is closed down, some patients' treatment still cannot be completed, we won't allow them to admit those patients. We also ask them to comply with laws governing hospitals. This is unprecedented, but we will work according to the necessary procedures. We will learn from this experience, and we will write up a procedure that will govern future hospital closure. In terms of timetable, we have to first enhance regulation of private hospitals. And perhaps this can only be completed after a year, but now the procedures are very clear. We know what to do. If you say that guidelines are needed, this may be completed after a year.
Yes, I can understand that. And lastly, I would like to ask about some documents. On the 21st of November, the DH provided a pile of papers to this committee, and the paper number is R59/3/GEN1. And for this paper, there are many attachments. So for Annex A, it is a protocol for inspection of private hospitals, nursing homes, and maternity homes. So is this protocol being used at the moment? Yes. And here it says version 2, March 2010. So previously that was in version 1. Do you need a document from us? Do you have it in your hand? Director, do you have the document in your hand? Yes, I do. So can you answer Mr. Leung's question? Yes. So can you provide version 1 to us? Because I want to know more about the regulatory procedures. And then in Annex B, here is an sample inspection checklist. So how do you use this checklist, Director? For the inspection checklist, it is for conducting annual inspection, and that's used before September 2010. So we were talking about this checklist, right? It has been used for 2 years, in 2009 and 2010, right? So for this checklist, there are different items on it. So how did you come up with these items? So for that checklist, it's related to the code of practice. These are the important items in the COP. And after the inspection, our staff will write an annual inspection report. So when it was formulated, did the ORHI do it alone, or it discussed with the private hospitals and it has adopted opinions from the private hospitals? Well, this is a checklist for inspection, so it's designed by our own staff. Yes, we've heard that it's been used for 2 years, and then in 2011 and 2012, this checklist was not used, right? So this is this checklist. So it was used in 2009 and 2010. So in the future, if a checklist is to be used again, then you will use this checklist. We will be adding more things to it. That's in Annex F and G. That is, we will incorporate the audit's views into it. They are in Annexes F and G. So that's about the land lease and land use, right? And also for inspection, we have made some optimization. Mr. Leung asked if you will be optimizing this checklist or you will have a new checklist. In Annex F and G for F, actually in September this year, we started to use this. And for Annex G, we have looked at report number 4, and that's about land supply, and then there will be another checklist. Because this was done in September, and we will follow up on this and see if further optimization is needed. All these documents have been provided to members. For Annex F, now if you inspect in a hospital now, you will use this checklist. And on a checklist, actually I see items that are different from the checklist we mentioned just now. So why have there been such changes? And for Annex F, there are 4 columns: satisfactory, partially satisfactory, etc., and not applicable. So how do you fill in this different columns? Are there standardized benchmarks? Well, for inspection, it's actually a patient-based inspection. So we will look at different areas. Now we will look at the procedures a patient has to go through in a hospital, and then we will see whether all these procedures have been complied with. So for some mild areas, so if it's not done that well, then we would put it under partially satisfactory. And all these are done by professionals. Well, the Secretary said in his opening speech, said that there are 11 plus 1 members in the professional team. Well, the Secretary may be humble, but that may also be a fact. That is, when it comes to different specialties, if you are not expert in that area, you may not know that too many things about that area. So when we look at this checklist, it covers a lot of areas. So for that inspector or the MO that's responsible for that, if it doesn't know too much about that area, what should be done? Now, I can cite an example. For example, there are some facilities that may be related to radiological equipment. Then, according to the law, they have to apply for a radiology license. So if there are problems with that equipment, other than the ORHI staff, we would also invite experts from other DHD units to take part in the inspection. Well, for the 1+11 establishment, has there been communication like this? Now, for example, pharmacy accommodation. There are objective benchmarks. Now, what kind of accommodations would be regarded as satisfactory, partially satisfactory, and unsatisfactory? Is there a set of clear guidelines for the inspectors to follow? Now, in a medical institution, there are many different areas. And also for hospitals, they have the governance bodies, and also for each specialty, there is a professional responsible for that. So in the course of our inspection, we will try to find out whether they have infection guidelines or protocols. We will ask the hospital staff to show us those guidelines. We are not formulating the guidelines for them. We require that they have their own guidelines, and then we will look at these guidelines and see whether they are in order. Well, for the medical field is actually very complicated, so we cannot have a guideline for each and every area. So we would ask the hospital to show us that they have the relevant guidelines and protocols. So the same situation may occur in hospital A and hospital B. And then for the inspector, if he goes to hospital A, he may take satisfactory, and if he go to hospital B, he may take partially satisfactory, right? Would that be the case because there are no standards? He would look at hospital A, look at its level, and then it would give the hospital A mark, and then we'll go to hospital B and look at hospital B's performance, and then assessment will be made. So we will look at the report submitted by the hospital, and then we will inspect the hospital personally. But you have not answered Mr. Leung's question. Well, it seems to me that she agrees with me. Well, can you cite an example, Secretary? Now, if it's the same situation, then I think it's very difficult for the director to understand what is meant by the same situation. Now, for example, if there are two pharmacies and the sizes are the same. Now, if you go to one hospital, you may think that's big enough because it only has 200 beds. But for another hospital, maybe it has 600 beds, so that pharmacy may not be big enough. So that's the same situation. But we are talking about different hospitals, and they are providing different services, so they may need different facilities. Yes, the Secretary is actually talking about proportion. Now, that is the size of the pharmacy, whether it is proportionate to the number of beds in the hospital. So this is something objective. So if you have such objective standards, then actually for both hospital A and hospital B, their results may be satisfactory. I'm also a layman, Chairman, but I want to know more about this. Now, objectively, there are forms. So on the surface, it seems that Audit and this committee may be satisfied with these forms. But when it comes to actual operation, if the inspector is subjective, then these forms would not serve their purposes. So I want to know whether my worry is justified. Yes, when I ask this question, I actually understand we have to believe in the professionals, and they can make their own professional judgments. And sometimes we cannot just look at cold figures and data. But if we have cold figures and data, we can be assured that their work is more guaranteed. So in 2009 and 2010, your staff designed a system, and that system may not be bad. So Mr. Leung wants to know whether the changes would bring about better results. Well, Mr. Leung is right. Not everything can generate quantifiable data. But of course, if there are quantifiable data, we would use them. But that may not necessarily be the case. Sometimes it is a professional judgment. And for professional judgments, different people may be slightly different. Now, we are going to write a report on this. So can we record this promise from the Secretary? That is, if there can be objective standards, then objective standards will be set. If there are no objective standards, and if we have to rely on professional judgments, then at least the inspectors would know each other's judgment standards. It's just like teachers giving marks to students' compositions. So they would come to a consensus saying that, well, if the student has written like this, then this level of marks will be given to the student. So can the professionals come together and agree on some consensus concerning inspection results? Yes, I agree. So now let's take a break. Do you want to break for 5 or 10 minutes? Because we have to adjourn the meeting by 12:45, but we can lengthen it by 15 minutes. So let's take a break for 10 minutes, and please come back